RR's Pediatric Nursing Channel. What is patent ductus arteriosus? Failure of the fetal ductus arteriosus to close within the first week of life. Review of fetal circulation. Oxygenated blood and nutritive material enters the fetal system through umbilical vein. The blood then travels to the liver, where it divides. Part of the blood enters into the portal circulation and the remainder joins with inferior vena cava by the way of ductus venosus. In the fetus, there is an opening between the right and left atrium, the foramen ovale, and most of the blood flows from the right into the left atrium, thus bypassing pulmonary circulation. The majority of blood flows into the left ventricle from where it is pumped through the aorta into the body. Some of the blood from the right atrium does not enter the left atrium, but enters the right ventricle and is pumped into the pulmonary artery. In the fetus, there is a special connection between the pulmonary artery and the aorta, called the ductus arteriosus, which directs most of this blood away from the lungs. At birth, when the infant breathes for the first time, there is a decrease in the resistance in the pulmonary vasculature, which causes the pressure in the left atrium to increase relative to the pressure in the right atrium. This leads to the closure of the foramen ovale, which is then referred to as the fossa ovalis. Increase in the concentration of oxygen in the blood leads to a decrease in prostaglandins, causing closure of the ductus arteriosus. Sometimes these postnatal closures are incomplete or absent, leading to the following conditions. Patent foramen ovale in the heart, patent ductus arteriosus in the great vessels, patent ductus venosus in the great vessels. Genetics. Familial cases of patent ductus arteriosus, PDA, have been recorded, but a genetic cause has not been determined. The recurrence rate among siblings is 5%. Chromosomal abnormalities. Several chromosomal abnormalities are associated with persistent patency of the ductus arteriosus. Implicated teratogens include congenital rubella infection in the first trimester of pregnancy, fetal alcohol syndrome, maternal amphetamine use, and maternal phenytoin use. Prematurity. Prematurity or immaturity of the infant at the time of delivery contributes to the patency of the ductus. Other causes include low birth weight, LBW, prostaglandins, high altitude and low atmospheric oxygen tension, and hypoxia. Small to moderate-sized PDA. Usually asymptomatic. Large PDA. 1. CHF, tachypnea, frequent respiratory tract infections. 2. Poor weight gain, failure to thrive. 3. Feeding difficulties. 4. Decreased exercise tolerance. 5. Infective endocarditis. 1. Auscultation, continuous murmur heard best at left upper sternal border. Hyperactive precordium with large PDAs. 2. Wide pulse pressure, bounding pulses. 3. Chest X-ray, varies, normal or cardiomegaly with increased pulmonary vascular markings. 4. ECG, varies, normal, LVH or RVH. 5. Two-dimensional echocardiogram with Doppler study and color flow mapping to visualize the PDA with left to right blood flow. 6. Cardiac catheterization is not needed for the initial diagnosis. Conservative standards include adaptation of ventilation by lowering inspiratory time and giving more positive end expiratory pressure. Fluid restriction that does not exceed 130 ml/kg/d beyond day 3 is also used. This has been found to have a high closure rate of patent ductus arteriosus, PDA. Closure of the patent ductus arteriosus, PDA, is stimulated by administration of prostaglandin synthesis inhibitors, such as indomethacin, 0.1 mg/kg body weight, is administered orally at 8-hour intervals, or aspirin, which is effective in premature infants. Indomethacin, indocin, effective in premature infants, 0.1 mg/kg body weight, is administered orally at 8-hour intervals. Ibuprofen, prophylactic ibuprofen, is also widely used. The dose used for ibuprofen is 10 mg/kg bolus followed by 5 mg/kg per day for 2 additional days. Cardiac catheterization. The use of the percutaneous route to close the patent ductus arteriosus, PDA, is becoming more common. Transcatheter occlusion is an effective alternative to surgical intervention and is becoming the treatment of choice for most cases of patent ductus arteriosus, PDA, in children and adults. Surgical ligation or surgical ligation and division remain the standard treatment of large patent ductus arteriosus, PDA, that require treatment in infancy. Indications for surgical treatment include the following. 1. Failure of indomethacin treatment. 2. Contraindications to medical therapy, example, thrombocytopenia, renal insufficiency. 3. Signs and symptoms of congestive heart failure, CHF. 4. Patent ductus arteriosus, PDA, found in an older infant. 5. Infants found to have an asymptomatic patent ductus arteriosus, PDA, after the neonatal period should undergo surgical ligation preferably before the age of 1 year to prevent future complications of a patent ductus arteriosus, PDA. (1) CHF, pulmonary edema. 2. Infective endocarditis. 3. Pulmonary hypertension/pulmonary vascular occlusive disease. 4. Recurrent pneumonia. Patent ductus arteriosus necessitates careful monitoring, patient and family teaching, and emotional support. Signs and symptoms. Watch carefully for signs of PDA in premature infants. Monitoring. Frequently assess vital signs, ECG, electrolyte levels, and intake and output. Adverse effects of indomethacin. If the infant receives indomethacin for ductus closure, watch for possible adverse effects, such as diarrhea, jaundice, bleeding, and renal dysfunction. Preoperative instructions. Before surgery, carefully explain all treatments and tests to parents, including the child, and tell them about expected 4 lines, monitoring equipment, and postoperative procedures. Postoperative procedures. Immediately after surgery, the child may have a central venous pressure catheter and an arterial line in place, so careful assessment of vital signs, intake and output, and arterial and venous pressures are needed, as well as pain relief.